Hello, I am Dr. André Theron, and I'm so glad to join you today to speak about the nerve ablation for the conservative management of osteoarthritis in hip surgery. Due to some time constraints, I did not include shoulder surgery. I will do that at some later stage, and you're welcome to ask any questions about that. But I thought that to cover one area well is better than to cover both areas not completely. Right, so first off, no conflict of interest to this talk specifically. I do develop presentations on ultrasound guided regional anesthesia and perineural catheters for Payung, South Africa, but that's not applicable. And here in the background, you see the beautiful mountains here close to where I stay. So I will talk about both conservative management of the unfractured and the fractured hip. The treatment is exactly the same. The ablation techniques are exactly the same, but I would like to put both in there because they do give us certain patient groups. First of all, hip osteoarthritis in the elderly. Worldwide, the WHO estimates that show that more than 500 million people have symptomatic osteoarthritis, and that is an increase of more than 100% since the early 90s. Also, 10% of men, 18% of women over the age of 60 have symptomatic osteoarthritis, and this includes moderate to severe forms. I won't be discussing the specific forms, but there are criteria that warrant surgery, and we'll just be talking about those patients. While hip osteoarthritis is the major reason for total hip arthroplasty, a significant number of patients do not undergo surgery, either because they don't want to, or because of medical conditions or others make them ineligible for surgery. Now, there was a Swedish study that found that 10% of patients, after 5 years of a follow-up, who were initially willing to have hip replacement surgery became unwilling. And that in this study, they had 70% who were never willing to undergo surgery, despite having significant or osteoarthritis of the hip that qualified them for surgery. Now, what makes them suitable or unsuitable? Let's go into some of the details. Firstly, among the patients with osteoarthritis, it's been shown that 10 to 30% of patients are unwilling or unsuitable. So of all the patients that you can operate, about 10 to 30% of them are ineligible. Patients may be deemed at high risk or unsuitable because of medical comorbidities, severe cardiovascular disease, poorly controlled diabetes, and poorly controlled other acute and chronic conditions. Severe obesity, now this is a relative contraindication, but severe obesity with a BMI of more than 40 is a strong indication for high risk of complications, basically. Surgeons don't want complications, so they tend not to operate these patients, but I don't speak about all surgeons. Some surgeons will operate anyone. Active infection, whether recent or existing, whether it's be urinary tract infections, other infections of the skin, ears, nose, or whatever, these also are make candidates unsuitable for elective replacement. And then inability to comply with rehabilitations. Patients with advanced dementia or severe alcoholism who may not be able to follow post-operative surgical instructions, and this may lead them to be a higher risk of dislocation or failure of the surgery. Then severe muscle weakness or neurological conditions, severe Parkinson's, which can limit the success of a new joint. All these patients are deemed less suitable or unsuitable for elective surgery. But elective surgery is one thing. But once the patient falls down, what happens then? Then you have a patient that, according to orthopedic surgeons, needs surgery. Family want you to do something. The grandma is in pain. Surgeon wants to operate. Now, the conditions that previously made this patient ineligible don't suddenly go away just because of a fracture. But in the mind of surgeons, this is exactly what happens. So hip fracture in the elderly is very common and causes high morbidity and mortality. About 20% of patients dying within 1 year of the injury. The primary management goals by the surgeon specifically is to stabilize the hip, reduce the pain, and restore pre-fracture function. Surgical reduction and fixation is the definitive treatment. So that's the obvious answer. There is a fracture. We need to fix it. Worldwide, only 5 to 10% of patients are treated conservatively due to their comorbidities. Some anesthesiologists just say no. These conservatively managed patients are bedbound for about 2 months while natural healing occurs. But during this time, we have certain problems and issues that we have to think about. There is severe movement-related pain, which makes nursing extremely difficult. Immobility-related complications are also pressure ulcers, which in and of itself carries severe morbidity. Delirium, pneumonia, deep vein thrombosis, and then oral analgesics are very ineffective for movement-related pain, especially for the hip fractures. And then regional anesthesia works fantastically well, but the problem is they only provide short-term or partial analgesia. You cannot continue doing femoral blocks for 2 months for these patients. So what now? First of all, I'd just like to discuss the innovation of the hip. There's some really good research that's come out recently, and I would just like, because I love anatomy, I would like to just refresh us so that we know what is it that we're blocking and why are we blocking the areas that we need to block, or neuralize in this case. First of all, the innovation of the anterior hip, the femoral nerve, one of the largest components there. It provides high and low articular branches to the anterior hip capsule. The high branches originate from the femoral trunk above the inguinal ligament. They course through the iliacus, pass beneath the iliopsoas tendon, between the anterior inferior iliac spine and the iliopubic eminence. And I'll show this to you just now. And they supply all 4 quadrants of the anterior capsule, inferior medially less consistently. There are low branches as well, and these are only present in about 15% of cases, and they most often supply the inferior lateral quadrant and travel through the inferior to the iliopsoas. Then, the obturator nerve, L2 to 4, and this has historically supplied more than 100% of specimens. Originates from the lumbar plexus and descends medial to psoas and enters the obturator channel, dividing into an anterior and a posterior branch. The branches may have a high, low, or both articular components. The high branches originate from within the obturator canal and descend down below the hip joint and recurve upwards to supply the inferior medial quadrant. The low branches arise from the posterior division and travel directly through a fine plexus to the inferior medial and inferior lateral capsule. Lastly, the accessory obturator nerve. These are only present in about 5 to 53%, so this is a wide range of patients, but it is something to think about. Courses superior to the pelvic brim in the same area as the femoral branches, near the ilio, over the superior pubic ramus. Okay, just here I would like to highlight this area. So we have the femoral branches, both the high and the lower branches, here between the ASIS and the iliopubic eminence. Here over the pelvic rim, we see these branches, and that will innervate the hip over here. This is the accessory obturator nerve with its branches. So you see that they are all in the same anatomical region and level. Then the obturator nerve, we have both the anterior and posterior divisions, and they then give the small plexus, remember, and the recurvature, where they supply the inferior medial and inferior lateral areas. And you see that they arise from a different component, not open to or not connected to this anatomical plane. Right. Then we're looking at the innervation of the posterior hip. Again, lots of nerves. Stay with me. This is important. The sciatic nerve, contributing to the posterior hip, is very variable, anything from 5 to 80%. It exits the greater sciatic foramen and usually deep to piriformis, supplying the posterior thigh, leg, and foot mostly, but the articular branches pass between the superior gemellus and the obturator internus tendons. They cross the lesser sciatic notch, and this will show you just now, and innervate the posterior superior capsule. Okay, here we see that picture. So this is the sciatic nerve, and we see branches of the sciatic nerve innervating the superior component to the hip capsule. Then further innervation, this is very important, nerve to quadratus femoris, most consistent contributor to the posterior hip. It is key interventional target for posterior hip pain. Passes through the greater sciatic foramen, deep to piriformis, obturator internus tendon, and the gemelli. It gives small branches to the iliofemoral ligament and then the inferior half of the posterior capsule. It lies below the sciatic nerve and is very accessible for intervention. Okay, then two more, the superior gluteal nerve and the inferior gluteal nerve. Superior has some articular branches, and it varies widely. Travels between the gluteus medius and minimus with the superior gluteal vessels. So you could specifically block them if you follow the superior gluteal artery, but that's not what we're going to do. We do it the easy way. Then provides motor supply of gluteus medius minimus and tensor fascia lata. Then it sends the articular branches descend deep to the lateral rotators to innervate the superior posterior capsule. The inferior gluteal nerve, very controversial and uncommon contribution. So this is not as important to block, but we will discuss everything that you need to know to manage these patients' pain. It emerges inferior to piriformis and runs deep to the gluteus maximus. And it may innervate the lateral and inferior lateral part of the posterior capsule, but less so than the sciatic nerve and the nerve to quadratus femoris. Okay. Right, here is what we're talking about. So here we have a superior gluteal nerve, and there we have its branches, and nerve to quadratus femoris with its branches, and the inferior gemellar nerve and its branches. Again, here we see specific anatomic areas where they pass through. Here is just another schematic of it. This shows high nociception. This is the anterior hip capsule. And posterior, you see very few areas of nociception, mostly mechanoreceptors. But there we see the superior gluteal nerve, we see the inferior gluteal nerve, sciatic nerve, and nerve to quadratus femoris over here. Then, chemical neurolysis. Why chemical neurolysis? Why not cryoablation or normal ablation? The reason for that is in our setting specifically, the ablation needles and the techniques are quite expensive, and pain management, especially chronic pain, if these patients are managed conservatively before fracture, the medical aids tend not to fund these types of procedures. So we have an expensive procedure that a patient needs to fund themselves. Whereas with chemical neurolysis, the costs are much decreased. There's fewer technical skills required, and the follow-up is easy. The agents that we use, firstly, it's used in palliative care mostly, or when radiofrequency or cryoablation are contraindicated or unavailable. As I said, in our setting specifically, radiofrequency and cryoablation are not widely available and very expensive when it is. And the target is the anterior hip capsule. Remember where I showed you that most of the nociception for the hip capsule is anterior, but posterior capsule involvement is also supported, neurolysis is supported by the posterior hip capsule neurolysis studies. The agents that we use, absolute alcohol, 100% or 90%, depends on what you have available, and then phenol, at least 6 to 10% are used. you need a final concentration of alcohol of more than 50% for a long-lasting effect. The alcohol protocols, what we usually do is we pre-treat the patients with local anesthesia, bupivacaine, because alcohol has no intrinsic local anesthetic properties. You have to give them analgesia before injecting the alcohol. It is extremely painful for these patients otherwise. But here we need to remember that you have to have more than 50% alcohol concentration. So depending on the volume of bupivacaine or other local anesthetic that you use, you have to keep the concentration of the alcohol more than 50% to have a successful block eventually. And these blocks are also to do a bupivacaine or just a local anesthetic beforehand. I like doing it this way and using the alcohol, mostly because you will know what the effect on your patient is before you do the neurolysis. So if the patient has no effects or very few effects, you may reconsider doing the ablation. Then you should assess the patients 10 to 15 minutes after injecting. You keep the needle in exactly the same place, and then you inject your alcohol. And you'll inject a 1-to-1 usually, 1 alcohol to 1 bupivacaine. Phenol has intrinsic local anesthetic properties, so you don't need to inject local anesthesia beforehand. But with the phenol, if you do inject it and there is either no effect or there is a motor component that you have inadvertent spread to a motor nerve, then you have blocked it and it is done. So that's why I prefer doing bupivacaine and alcohol. Or if you do want to do phenol, you can do a very low concentration, 0.5 to 1% phenol injection, first just to see what the effects are, and then to do higher concentrations to do the neurolysis. Then safety and procedural considerations. I prefer staged procedures, especially in frail and vulnerable patients with these high comorbidities. Remember that the alcohol will eventually be absorbed into the patient's system. So if you give a large volume of high concentration alcohol, you will get your patients drunk as a skunk. So it will be absorbed. So make sure that you are aware of that. You have some minor side effects, tachycardias, transient hypotension that might occur. And make sure your patients are adequately hydrated. Just like a night of drinking, you want some water on board. Then vasopressors should be available, especially in acute hip fracture patients who are sometimes dehydrated as well or have had blood loss. The ultrasound guidance of the chemical neurolysis, let's talk a little bit about that and to discuss the exact way of doing it. First of all, the sonoanatomy of the anterior hip. Now, I'm sure that you know this picture, but I will go through it. So the idea to block the anterior hip capsule is, remember the PENG block, pericapsular nerve group block that we use for pain management, especially in fracture patients. We have the anterior inferior iliac spine. We have our iliopubic eminence right over here. There's our femoral artery. Remember that the femoral nerve is right above here, above the iliopsoas. So iliacus usually there, and the psoas tendon right here on the pelvic rim. What we aim for is injection close to the iliopubic eminence. Remember from the anatomy that I showed you, we have both the femoral and the accessory obturator branches that pass in this anatomical plane. So you would inject deep to the psoas. And as you inject, you would want to see spread underneath here between bone and the muscle itself. If you're having very difficulty injecting, it might be that you are very close to the tendon. It's very difficult to inject there, or it might be that you are in the periosteum of this area. So you might just need to reposition if you're close to the tendon. And if it doesn't want to inject, if you're on the bone here, you might have to just retract your needle by 0.5 millimeter or something like that, and then inject, and then you will see good spread in this area, and that is what you want to see, because all of those nerves pass in this anatomical plane. This is the ultrasound position that you want to see with our needle injecting close to the iliopubic eminence. And then I do first the bupivacaine injection, followed after 15 minutes if there is a good pain effect with the alcohol. The second injection, remember that the obturator itself, both the anterior and posterior branches with the high and low articular divisions, pass here from the obturator foramen, and they supply the inferior medial and inferior lateral components. So to get that picture, what we want is firstly have our ultrasound probe in line with the femoral head, the neck of the femur, as well as the superior medial acetabulum. We can see all of them, and here we can see the fracture site, and this is a patient with a fracture, and this is exactly the same procedure whether the patient has a fracture or not. You will then slide your ultrasound probe inferior medially until you can no longer see the neck of femur, so it disappears, and you see the inferior medial acetabulum, and that is the goal for injection, so that you come in from laterally to medially, connect the inferior medial acetabulum, because remember that both those branches pass in this area, so injecting your local anesthetic in that area, you will get that direct plexus and the component that recurves. So this would then give you complete coverage of all the components of the anterior hip. And this is excellent cover for most patients. Some patients, however, will still experience pain from the posterior compartment. And I just want to go through that as well. What we see over here is the ilium with gluteus maximus, medius, and minimus. Probe position number 1, and remember to use a curvilinear probe for this. You slide inferior medially until you reach, you see piriformis, the ischium, and the sciatic notch over here. So there's nothing there, certainly. You had a bone, and then inferior medial until that you see the notch there. Remember that the sciatic nerve is right over here. So please do not inject at this level. It is a bad idea. From here, you follow towards the ischium and you go inferior laterally, where you see ischium, you see the neck of femur, you see the greater trochanter, and you can still see a component of piriformis. You will inject from medially towards laterally in the area of the neck of femur in the direction of the greater trochanter, so you'll be injecting in this direction so that you have spread over this component right over here. Here we see the needle connecting below piriformis on the neck of femur there, posterior component, close to the greater trochanter, and then you inject your local anesthetic first and then the neurolytic agent, or if you just use phenol, you will inject phenol at that level. So what can we expect? How effective is it? In the acute inoperative hip, we see 71% achieve satisfactory pain relief with the anterior neurolysis alone. 94% experience relief when the posterior neurolysis is added to that. Functional outcomes of anterior neurolysis. 50% of patients are able to sit out of bed within 5 days. 15% are able to walk without aid within 4 months. And I would like to thank you. So I hope that this has helped you. I know this is a little bit long. I do apologize for that, and that's why I did not include the shoulder as well. I think the anatomy is very important. Do the neurolysis. I have used it for many patients. They are exceptionally happy, whether this is conservative treatment just of osteoarthritis or management of the patient with a femur fracture that you do not want to take for surgery. Not all of them have to go for surgery. Thank you for your attention, and I hope you enjoyed it.